Welcome to this UROwebinar, Empowering Nurses in Metastatic Prostate Cancer, Balancing Toxicity Management and Shared Decision Making. Today, we will explore the pivotal role of nurses in managing side effects and fostering shared decision making in metastatic prostate cancer care. Together with our experts in site and real-world strategies, we will aim to equip you with the tools to enhance patient outcomes and navigate the complexities of challenge journey of prostate cancer. So let's get started. Together with me, we have a multidisciplinary panel, and the first speaker will be Dr. Natalia Vidal Crespo from Cartagena, Spain. She will talk about managing toxicity in metastatic prostate cancer. So Natalia, the screen is yours.
Thank you. Let's see. Okay, everyone seeing this? Okay, so first of all, I'd like to thank all the organizers to inviting me to participate in this very interesting webinar. We're going to talk about managing adverse events on systemic treatment of metastatic prostate cancer. We could be talking about this for the whole hour, so I'm going to try to be concise. I have no potential conflict of interest to report, and we're starting. You've seen these slides many times. This slide summarizes all current systemic treatment options we have in the different stages of natural history of prostate cancer. They all come with concomitant ADT, that's it, either with orchiectomy, an anti-androgen, or a GnRH agonist or antagonist. So we're going to start with ADT adverse event. In this slide, we can see all adverse events with their prevalence. I know this seems like a lot, but it can really be resumed on the next ones. So we're going to have hot flashes, gynecomastia, decreased bone density, and therefore an increased risk of bone fractures, some level of anemia, which is usually mild, fatigue, cognitive changes, low libido, and erectile dysfunction. We also have metabolic syndrome, so we usually have increases in weight, body fat, increased risk of diabetes, hypertension, hyperlipidemia, and most importantly, patients on ADT have an increased risk of cardiovascular events and cardiovascular mortality. So as nurses, early detection of these issues and patient education is going to be essential. We're going to start with these last ones. In these patients, we need to monitor weight, blood glucose, lipid profile, and blood pressure, and then treat in case of impairment. And then, other than that, the effect of exercise has been studied multiple times. In this meta-analysis, they included 28 randomized controlled trials on the use of exercise, and it saw a reduction in body fat mass, in waist circumference, and systolic and diastolic blood pressure. Apart from monitoring cardiovascular risk factors, we should evaluate cardiovascular risk with the score and send those patients with high risk, and especially those with very high risk, to a cardio-oncologist. One strategy we can follow is choosing a GnRH antagonist instead of an agonist for patients at risk, as the cardiovascular risk for both the decarrelase and relugolist has shown to be lower. For the bones, there are multiple studies that have addressed the use of bisphosphonates and denosumab in both hormone-sensitive and castration-resistant stages with positive results. So we need to ensure that patients who need them are taking both protecting agents, that is, those with castration-resistant illness, then with those with osteoporosis, and for osteopenia with a high risk of fracture. And we should ensure that patients take an adequate intake of calcium and vitamin D. Hot flashes, they may not be as serious as the previous one, but they are very, very common and very bothering for the patient. So although there is a lack of evidence for these strategies, there are very simple recommendations that we can give to the patients, such as dressing in layers, avoiding triggering stimuli like hot meals, coffee, alcohol, or tobacco, using cooling devices, cognitive behavioral therapy, or yoga relaxation or mindfulness techniques. Some small studies address the use of acupuncture in these patients, and again, although there is no good evidence, they all seem to reduce hot flashes with no adverse event, so this could be worth a try for some patients. And there are also multiple drugs that have been tested as well with positive results with a reduction of hot flashes frequency. Some of these drugs have been compared to one another, and it's a study compared venlafaxine, cyproterone, and medroxyprogesterone, and all of them demonstrated to reduce hot flashes, but the effect was better for cyproterone and medroxyprogesterone. As for fatigue, it can be as well very bothering for our patients, and again, in this meta-analysis that included 20 randomized controlled trials, supervised exercise saw an improvement of cancer-related fatigue and overall quality of life. Following with further treatments, these are the adverse events for abiraterone from the Latitude trial. Again, we're going to focus on the most relevant ones. We have hypertension, so we should monitor blood pressure in these patients. Second of all, hypokalemia, again, monitor potassium. Hepatic transaminases can be altered, so we should monitor them as well as bilirubin, and then in some cases, maybe treatment with abiraterone may need to be stopped. And finally, we must know there is an increased risk of cardiovascular events, so patients must be evaluated with a score as we say with other ADTs, and maybe choose another ARPI if the risk is high. For apalutamide, enzalutamide, and darolutamide, this table summarizes most relevant adverse events from the non-metastatic CPRC studies. We can see fatigue and hot flashes were common in these patients. We've already talked about the management. Some level of digestive symptoms such as nausea and diarrhea that can be manageable with support treatments such as antiemetics or loperamide. Hypertension and cognitive impairment, they seem to be more common with enzalutamide, and RAS and hypothyroidism are very specific with apalutamide. For the management of RAS, we should give skincare recommendations to patients, such as using sun blockers, light emollients, and avoiding hard soaps, alcohol-containing products, or long baths. Regular monitoring and asking for a starting sign is advisable as well. And then, as we can see, when we already have the RAS, for grade 1, grade 2, topic agents are used, and in grade 3 patients, apalutamide needs to be stopped and oral corticosteroids need to be added to the treatment. Continuing with chemotherapy, here we have the adverse events described on the TAX-327 trial and the grade 3-4 for the CHARTED trial for docetaxel. Again, we're going to focus on the most relevant ones, that in this case, they are probably neutropenia, with a third part of patients from the TAX-327 trial experimenting grade 3 neutropenia, but still, thankfully, only 3% develop febrile neutropenia. We also have fatigue. We've already talked about the management. Alopecia, we should tell them to patients so they know what to expect. Some level of digestive problems with nausea, diarrhea, or stomatitis that are manageable with support treatment. And also, almost 1/3 of patients are going to develop nail changes and sensory neuropathy. So we should recommend proper nail care, avoiding trauma, harsh chemical products, or cold temperature. As we can see for the charted table, the rates of grade 3-4 are low. For cabazitaxel, adverse events are very similar, but from the TROPIC trial, we can see neutropenia had higher rates. But then we have another study that with a lesser dose, there was no difference on the oncological results, and they diminished the rate of febrile neutropenia to 2%. So this is now the recommended dose. And very quickly, how do we manage neutropenia? We should not administer chemotherapy for grade 2 or lower. For those patients with febrile neutropenia, reduced dose. Very, very important, we must instruct the patients that if they have a fever, they need to consult, and then the use of DCFS. I'm going to pass this quickly. For combinations, we need to know that the addition of ARPI to the chemo is not related with a high risk of adverse events. And for PARP inhibitors, we can see here the table for olaparib monotherapy. Most relevant toxicities in these groups are hematological toxicities, particularly anemia, that in the PROfound trial was 21%, grade 3 anemia, that is anemia that requires blood transfusion. For non-hematological toxicities, most frequent or most relevant, again, fatigue, and gastrointestinal toxicities such as nausea, diarrhea, or decreased appetite that we can manage with support treatment. For the combinations, we do not have direct comparisons against monotherapy as the studies compare them with ARPI monotherapy, but we can see the type of adverse events are similar. Again, most relevant ones are hematological toxicities, with anemia being the most relevant. For example, in the Talaproto study, almost 50% of patients had a grade 3 anemia. Neutropenia and thrombocytopenia, they are also present but less frequent, and the grades of grade 3 and 4 are lower. So how are we treating anemias? We said interrupt the drug until hemoglobin is more than 9. For grade 3 anemias, blood transfusion, and then when hemoglobin is more than 9, we start treatment at the previous dose if the hemoglobin was if the anemia was grade 2, and then at a reduced dose if it was grade 3 or 4. If we have a recurrence, doses can be further reduced. And really, really important, if the patients do not recover after 1 month, they need to be referred to the hematologist, as it has been described a 1% risk of myelodysplastic syndromes that need to be ruled out. Very similar for neutropenia and thrombocytopenia. We're going to interrupt treatment for grades 3, 4 until grade 1, support treatment if needed, and restart a reduced dose. And again, the same, if they do not recover after 1 month, refer to the hematologist. Another treatment type, Radium 223. This is usually well tolerated. Most commonly seen adverse events are again anemia and thrombocytopenia, although they are less frequent and less serious than with PARPs. Some patients may present with diarrhea as well, as the drug has gastrointestinal excretion, but we can manage it with support treatment. And last, we have lutetium PSMA. Most common adverse event of lutetiums are going to be, again, fatigue, nausea, and anemia that we've already described how to manage them. And then a very specific adverse event for lutetium is right mouth. This is because the PSMA is also expressed on the salivary glands, and that's something patients can complain about as well. So to conclude, in order to manage correctly all side effects, we need to know them and learn to identify them. Patients must know as well what to expect from treatments and when to come early. Treatment must be selected for every patient to diminish potential individual risks, as we said, for example, for cardiovascular risk. Adapted exercise for all patients is going to be of help, as we've seen most treatments can cause fatigue, and it can also help with cardiovascular risk and metabolic syndrome. Most adverse events are going to be manageable with support treatments, but sometimes those adjustments and even drug interruptions are going to be needed. Thank you very much.
Thank you very much, Dr. Vidal. I want to remind the listeners to this webinar that we have a Q&A box down. So if you have any questions that could be replied by the speakers, please write them. So we will be able to read them and open discussion with the experts that we have in our webinar. Also, I want to remind the listeners to this webinar that we have a late cancellation. So the last lecture that's called Psychological Impact of Toxicity Supporting Mental Health in Metastatic Prostate Cancer. We are not giving this lecture. Perhaps if we have spare time, we are going to do an open discussion. So type your questions, and if there are no questions, by the time I want to ask you, Natalia.
Yeah.
What is the approach in your department for metastatic prostate cancer? Not yours. What I mean is,
for the nurse
behind who helps you in the care of these patients, and at the same time, I know that it's important to know all the adverse effects. We have seen that there's a lot of adverse effects that we should care about. But do you encourage your patients about these adverse effects? Do you help them how to identify them? If they have anything related to their treatments, to come to the emergency department? I mean, I want to a little bit to know what is the bureaucracy in your department behind prostate cancer.
So we're really lucky because we have a small group of nurses that work with us every day. We have 3 nurses on our department that are every day there, and they're really easy to contact with for the patients. So it's usually when some patients have a problem with the treatment, that is for this treatment or other ones, they usually come with no appointment and ask them, and that maybe if we need to, and if they have any doubts or anything, they come to us. But the first approach is the nurses, and for this. In concrete, these patients with metastatic prostate cancer, when we're seeing them on the specialist consult, the prostate cancer consult, they are first seen by our nurses, and they monitor, as I said, blood pressure, weight, etc., and give some education for them. I think it's important that patients know, at least, for example, as I said, for the apalutamide RAS, that they know that it is, if they start with some signs of RAS, they come early, so it's going to be easier to treat if we have a grade 1 RAS and that we've seen early, than if the patient waits and waits and waits and then comes with a grade 3 RAS. And for that, for all
and Natalia, do you know that well, I mean, it's obvious that prostate cancer treatment has changed completely in the last 10 or 15 years. ADT is very easy, let's say, or at least urologists were very, very familiarized using ADT and recognizing adverse effects from ADT, especially fatigue, asthenia, gynecomastia, and all this stuff. But now we have entered in a new era of a lot of new treatments. PARPs inhibitors, chemotherapy, lutetium, and so on. What do you think would be the best strategy to educate urologists or educate all those that are dealing with these patients to handle the drugs, to recognize adverse effects? Do you know that is anything running around like to educate healthcare professionals in how to deliver these drugs, how to recognize adverse effects, how to treat the adverse effects, etc.?
Yeah, so as I said on the presentation, like I think the most important thing is that we know the adverse event that we can find, because maybe the patients, they can come and they are 5-10 minutes with us and they are not telling us everything. So if we don't ask for some adverse events, they maybe not really think that this thing that they're feeling fatigue or anything like that, and they're not relating that to the treatment, and they do not tell us if we don't ask. So it's important that we do know what we can find with these treatments, so we can ask the patients for it and identify early. I think it's the most important thing, that we know all adverse events for the treatment that we're using, as well as drug interactions, etc. But the most important thing is to know. If we don't know what we're looking for, we're not going to find it.
Well, thank you very much, Dr. Vidal. So we can move to the next speaker. We have Corinne Tillier from Amsterdam. She's representing the European Association of Urology Nurses. And the lecture is entitled "The Role of Nurses in Shared Decision Making." The screen is yours. You can start.
Thank you very much. I tried to open the video, but it's not open. Doesn't matter. Do you see my slides? Well,
yes, we see it now.
Yeah, you see. Okay. I don't know why I cannot open the video, but my name is Corinne Tillier. I'm a PhD, a nurse practitioner at the Netherlands Cancer Institute in Amsterdam, and I'm going to tell you the role of the nurse in shared decision making. I don't have any conflict of interest. Well, we just hear from Natalia that you saw that multiple treatments for metastatic prostate cancer have similar efficacy. And well, you see that patients are facing with complicated treatment choices, and it's difficult for them to make a treatment decision. Since the data of several phase 3 trials of the triple therapies have been reported, docetaxel as sole addition to ADT is not longer a valid option in the majority of the patient if an RP is available and there's no contraindication to use one, but that Natalia just told us. You have several steps for shared decision-making process. And the step one is important, is the multidisciplinary team who gives the possible treatment option, of course evidence-based, and the options are dependent of stage of disease, of course, and also dependent of comorbidities and performance status of patients. And step two, the clinician gives the treatment option to patient, of course, taking into account the patient preferences, beliefs, values, benefits, and risk of treatment. And usually, in most of countries, after the discussion with the clinician, with the doctor, patient goes to the nurse, who begins again about the treatment options, and who takes more time than, I don't know, Natalia said just 7 minutes for consultation, 7-10 minutes, but nurses usually have more time for patient, and then we can take the time just to explain everything, and that, of course, that's important for patient-centered treatment decision. So the nurses are really important in the shared decision-making on that, because of the educating patients about the treatment option, which helps reduce indecisions and anxiety and provides reassurance in patients. Nurses help patients understand the benefits and potential complications of each treatment choice, enabling them to make decisions aligned with their values and concerns. In addition, in most of the in the country of North Europe, UK, Denmark, the Netherlands, we have nurse practitioner or clinical nurse specialist, and they offer the expert advice on symptom control. They deliver treatment and provide continuity of care. They help patients understand complex medical information, thereby empowering them to participate actively in decision making. And the step 4, we decide together on the best option. When I say together, it's including doctor, nurse, patients, and patient with family or partner. I mean, it's important too, but I will tell you later. And then you evaluate if the treatment choice for patient is reasonable, or if you have any concern. But what is important in a shared decision-making process? It's important to have empathy. And empathy relies on the nurse's capacity to relate the patient's perspective without imposing their own experience, point of view. Then we have to listen very actively to patients. It means that we need a non-judgmental listener. You had notes and neutral comments. You give a neutral comment such as, "Oh, I see," or you can give encouragement to patients. "Could you give me an example?" It's important to say that the dialogue based on open-ended reflective question, and it means that you try to avoid a yes or no answer when you ask a question. You should encourage a patient to tell their story, because it helps to build empathy and trust. That's just what I said. And you need to involve the family and friends. These are very important people in patients' life, and they are a part of the process of shared decision making. And then you have, of course, the shared decision making. Well, I just told you, you need a good communication, a good relationship, and to enable patient and doctor and nurse to talk freely about the choices and to weigh the pros and cons of treatment. And then you come to understanding needs and preference of patient. But therefore, you need you need the holistic needs assessment. You have 6 pillars of holistic needs assessment, and the nurses conduct holistic needs assessment to identify the level of distress and initial concerns of patients. Physical, psychological, spiritual, and social needs are included in these assessments. And the assessment, the holistic assessment, helps tailor support and care to individual needs, ensuring that treatment decisions consider the patient's overall well-being. I will give you at the end
So we can solve this while we get communicated with Corinne. We can invite our next speaker, Eric Bryers. Hello, Eric. How are you? Hope you're okay.
I'm fine.
So while we connect with Corinne and we solve her technical problems, we can have your lecture about what do patients have to say in shared decision making. Eric is representing the patient office from the EAU, and he's very involved in all the EAU patient initiatives. So Eric, the screen is yours.
Okay, I will share. Hope you can see my screen now.
We can see it perfectly.
Okay, so thank you, and ladies and gentlemen, it's my role to talk to you about the role that the patient has in shared decision making. And this is an important role. Let's find. I have no conflicts of interest, but I would like to start to go to what do patients in fact want. So they've been diagnosed with cancer, and like for all diseases, they want a cure for their cancer. And that's why we need to find cancers when they are curable. But if that's not possible, as patients, we want good control over the progression of the disease. Sorry, and this control can go with a lot of side effects, but it can be soft control, not too many side effects, or hard control. And then we would have a lot of side effects, which are sometimes very unpleasant, and we'll go a little bit on that. We do know as patients that we cannot have our old life back. If your prostate was taken out, it will not grow back. And we want quality in the end of life. Now, what is the objective of shared decision-making in cancer? Well, the patient and the doctor, nurse, they need to make a decision for the future. They have to decide on a treatment, and they have to make this decision together. And the basis of the decision will be information. It will be knowledge. So the scene in shared decision-making is, on one hand, in one corner, you have the patient and his relatives, his group of friends, and they get some bad news. And they get a mission. They have to find out what can be done about this bad news, what can be the treatment, how will their life continue. And in the other corner, we have the professional team. They're the doctors, the nurses, and they need a decision from the patient to carry on. So this is the one corner. We have the patient. He is there. Patient has a partner. That can be a wife, it can be a husband. There is the inner circle family, which is a separate group. That is the family with the children. There is the inner circle, which we might not know. Perhaps there's someone else in the game who may play an important role. We have the group of close, not so close friends. We have workmates. We have others who care, and we have fellow patients. And for some of the patients, this group also of the fellow patients is important because they have been there, they have done that, they know the disease, and they can give them the inside story. We have the healthcare professionals, and we have doctors, nurses. They have all the knowledge. They have the medical knowledge, treatment knowledge. They are experts on benefits and side effects. They have the knowledge, and they have a uniform. You will recognize them. Now, this is a way we can present this. issue, this table. This is the professional level. You have knowledge of the disease and knowledge of treatments. For patients, when they are diagnosed, this level of knowledge is very low. It can be completely absent, where for the professionals, they know it all. They have this knowledge. And what is needed is that we can promote patients into this level at a reasonable level of knowledge of treatment and disease. Some patients have already a nice level of knowledge. Sometimes a urologist gets prostate cancer. This is the personal level of the patient, and the patient has his priorities, he has his preferences, he has his way of life, he has his preferences on sexuality, on living with his partner, his financial means, and this level is not known to the doctor, because we think sometimes that it's only the patient who has to learn things. No, it's also the doctors, the nurses who have to learn more about the patient. Because at the moment of diagnosis, the doctor and the nurses do not know this man. There is the general practitioner who is the bridge between them. He has been working with this patient for perhaps many years, and he has some insight in the family and the personal preferences. Now, there is an issue here. We have to bridge a gap between those who know and those who don't know and should know, both ways. So where is this gap? Well, all our patients have different levels of learning capacity. And we can use a proxy for that, and the proxy for that is IQ, intelligence. And just to make it very broad, 68% of the population has average intelligence, average learning capacity. There is up and down. 16% are below average, 16% are above average. That is IQ by definition. Now, where are our patients? Well, the patients are spread all over this IQ universe. We have very low and very high intelligent patients with very high learning capacities. And where are you as professionals? You are at the right-hand side of this curve, all of you. You are at the above average and in the right-hand side of average. You're all very clever people because you could learn this, and you must now bridge the gap with the patients. It will be easy with patients from the same high intelligence. And they don't need to be doctors. They can have a training as a scientist, and it's easy to talk with them. But if you have to talk and communicate with someone at the left-hand side of this curve, it may be very challenging and very difficult. Now, it is interesting to also know, if we look at preferences from patients, to know what are the biggest influences on quality of life for the patient. Now, UROwebinar did the UPROMS study, and I heard from Dr. Crespo immediately about nausea and hot flushes. What is most feared by patients, what has the highest influence on their quality of life, it's their sexual quality of life, not hot flushes. And then urinary incontinence, hormonal problems, urinary obstruction, and finally bowel effects, which are different for radiation treatments and for surgery. Now, if we look at sexual function, just to go into one or two of the side effects, then we see, and this is disregarding the treatment, it's everywhere sexual function has been pushed down, radiation therapy inclusive, chemotherapy inclusive. It's going down from a normal 61, 58 to a median of 22 or lower. There's also incontinence. And here there's a difference. Patients who got surgery, they score about 67, and the others, they stay very high. So the incontinence problem is more for patients who had surgery before they got androgen deprivation therapy. Then they have the same issues with incontinence than they had before they got androgen deprivation therapy. We also questioned partners of patients. These are then partner-reported outcomes, so PROMs. And what we asked them, and there were more than 1,300 respondents, is an expression like, I was given information about intimacy from doctors and nurses. We learned that 60% disagree with this statement, which means they were not given information. 64% were not given information on sexuality, which is the biggest fear of the patient. So no information on this. And they also said more than 50% they had to find the information by themselves, both on intimacy and on sexuality. So this is the part of sharing and getting information. Now, patients are risk takers. If you have a serious disease, so a disease with a high burden, then they would accept to take high risks. And a risk like the side effect like impotence. If they get ADT, they will be impotent. Exceptions notwithstanding, some will not, but most of them will be impotent, and they know this, or they should know this. Now, if we go back to our scheme with our patients, now, if you want to come to a decision, if you are talking to peers of you, so someone with the same educational level, you can go into what we call a negotiation model. You can try to make them understand what the options are. You get some information back and you go on and off and you come to a decision. If you have to do with a patient with low learning capacities, to the left in the curve, then you may have to go to the old paternalistic model, which today we do not like to see, but in some cases it is necessary. Now there is something more, and it's already been said, that is empathy, but there's also emotional intelligence. It is exactly like in the other IQ. 68% have an average emotional intelligence, 16% under, 16% above. And it is independent from your intelligence, which means that you can have very intelligent professionals with very low emotional intelligence, and you do not want them to talk to patients. Now, if you then look again at our distribution of patients, then you get that can conclude that your emotional intelligence is very important. If you have to do with a patient with a low learning capacity, you will have to come closer to this patient. Whereas for your peers with a high learning capacity, it's less important, but it's never unimportant. Now, if we look at shared decision making, we did also ask this question as UROwebinar on a lot of patients, thousands of patients. And if you look at the bottom, you see the distribution over different countries. And then you see that the Netherlands have a score 37 out of 45, which is quite high, where Portugal scores 25 out of 45. So this is a big difference between two European countries. So they do not work the same. At the top, we have the different treatments, going from active surveillance all the way to radiotherapy and androgen deprivation therapy and chemotherapy. And there you see that it's across the line about the same. So there is a lot to do because the score could go up to 45. Now, if shared decision making is not well done, so both parties have not done the job well, then we come in the realm of decision regret. Decision regret, big study in UK, 17,000 prostate cancer patients. Of these, and they were non-metastatic. That's important to say. And they were questioned 18 to 42 months after diagnosis. 37% say, I have no regret. And 20% say they had moderate to severe regret of their decision they took. If then we look at the kind of treatments, only active monitoring is below these 20 with 17% decision regret surgery and external beam radiation therapy both score 28%. If we look at the relationship between being involved in shared decision-making and decision regret, this is shown clearly in this scheme. You see at the left those who say and claim, yes, I was definitely involved in shared decision-making on my treatment. They have in red the lowest level of moderate to severe regret. Those, the third column, who say nothing that I gave has been taken into account, their decision regret is the highest. So, come to a conclusion. Still today, too many patients are not fully informed about side effects and about before the treatment. They are not informed on potential solutions for the consequences of their treatment, or too late, and this also makes sure that valuable time is lost to preserve their quality of life. The sooner measures are taken to work against these or to solve the side effects, the better for their quality of life with their partners and family. And lastly, shared decision-making is on communication, because we have to talk to each other and exchange. Both parties have to learn from each other. Good shared decision-making leads to less decision regret, and that's what we want. And if you discuss side effects, it's important to explain what can be done about them, and this should be done before you start that treatment. And with this, I thank you for your attention. And if there are questions, please do.
Thank you very much, Eric. I want to remind the listeners that we have the Q&A box down, so write your questions so we are able to reply them live. And by the time we receive some questions, I mean, in this webinar, it's clear that we have found that shared decision-making is a collaborative process where different healthcare providers and patients can work together to make decisions about the treatments, care plans, and so on. But we see from the presentation of Eric that we as healthcare professionals, perhaps we're not doing good. We are not doing good. We have many places to get better. And I want to ask you, Eric, a personal opinion or a personal experience. What has been the most helpful thing your healthcare team has done to make you feel part of a decision process making? And from your point of view, or with all the data that you have presented, what can be improved or how can we improve from your perspective?
Well, one of the big problems which I see is that very often there is a lack of time. So we are very happy, and I'm from Belgium, and Corinne is in the Netherlands. We have specialized onco nurses, and they have been given more time to talk to patients. But the nurse and the doctor have to work as a team. So for the patient, it's important that his treatment is carried out. It will be carried out by a doctor, and this doctor should know what the nurse knows. So we have to be sure that the communication between the experts runs smoothly, that they tell each other what they need to know, and that they talk to the patient, they listen, and that the patient has enough time to work through. Because for patients, what they hear, you must imagine that for patients who get the communication, you have prostate cancer, it will not be said like this, but they might not know that they have a prostate for more than a week. And all of a sudden they have cancer to something they don't know. They don't know the function. So there is really an awful lot of ground to work through and information to catch, knowledge to acquire for the patient, who then has to decide, what will we do about this problem?
So basically, I think one of the main things that we need to solve at least in some countries as Spain or Portugal, is time, right? We need time. We need time to spend with patients, and we need to look for a common language to talk to them so they can better understand disease and the treatments and everything that will happen from the diagnosis to the treatment pathway.
Yes, and also one of the things that I witnessed for myself, I did not have metastatic cancer, but I had a high risk treated. The clinicians also have to refer the patient to someone who is specialized in the side effect that this patient may have, because we cannot expect that every urologist can, let me say, place a sphincter or can put an implant. He has to refer, and he has to do that if he feels that the patient might be helped with that or might need that. Refer them to a colleague who can do that, and do not keep the patient too long with you if you can solve that. And that's so extremely important, and the patient will be very grateful to the urologist that he did refer him.
Thank you very much, Eric. It's very, very insightful. It's very insightful to listen from a patient all what we can do to get better. We have a comment in the chat box. A really nice presentation, Eric. I totally agree. I think a major issue is time. We need to talk and inform our patient. Because this is an ideal task for nurses, but there's also a little time to inform. We see the patient to inform them about the treatment, but it's limited. If we take more time, who's going to pay for this? This is probably a question for a politician rather to us, yes. Right? Okay, we have our representative from the EAUN, Corinne, back. So in the last 10 minutes of the webinar, yes, we can finish the presentation and have some discussion on your presentation. So thank you for being back, and you can share the screen.
Yes. I'm very sorry. It was something happened. I'm in my hospital, and it was a disconnection of internet. It's never happened, and it's happened tonight. It's very crazy. Well, I was talking about the holistic needs assessment, which are very important, and I was just telling you that a recent survey from 2023 in patients with metastatic castration-resistant prostate cancer showed that improving overall survival remained the highest priority for patients, but patients are willing to sacrifice some survival to reduce the risk of requiring radiation to control bone pain, delay of fracture or bone metastasis, and experience less severe nausea or fatigue. So quality of life is, of course, important for patients, but the overall survival too. Well, yes. What is important in shared decision making is also the communication and coordination. And nurses act as key communicators between patients and the healthcare team, and they ensure that patient preferences are communicated effectively to other team members, such as oncologists or urologists. It's important to facilitate a cohesive approach to care. And of course, Eric said, just said about the emotional and psychological support. It's also important, given the emotional burden associated with cancer treatment decision. Nurses provide essential psychological support. It's important because patients are facing with fears and anxieties, and it could give an influence on the decision-making process. I want to just to talk with you with two cases of patients. The first patient is a patient who is 60 years old. He's from my hospital. He's from Mexico, but he's living in the Netherlands since 30 years. He's married with an oncology nurse who's working in our institute, but doesn't matter. But she's used to treat to have patients with cancer. They have two children. And I have to say this patient speaks and understands Dutch very, very good. In March 2018, he underwent a prostatectomy with lymph node dissection. It was a PT3B and 0, a mix. You can see a lesion score 8, And then in November 2020, he developed a metastatic disease, lymph nodes and bone metastasis. And it was a really difficult decision-making process with this patient because it was difficult. He refused everything, everything you could propose, and the ADT, what the multidisciplinary team advised. He said, no, I don't want. Then we try maybe bicalutamide, and we explain everything. We even send him to a psychologist, but he said, no, I don't want. I want to remain a man. So I prefer to die earlier than to lose my, I don't know how you say in English, to lose the fact that I'm a man. So you can see the development of the disease in this patient. And now the recent PSA was up to the 1,200, and now he received the end of life care, sorry. And then we have another patient, and he's 78 years old, he's married, 2 children, but they're adults, and he has a own business. He sells old-timers, and his business is his patient. His son has taken over the business, but this patient still wants to keep working, so he buys cars abroad in Spain, in France, in Belgium, everywhere, and he drives back with the car, with the old-timers, to the Netherlands. And it's crazy because I didn't see that this patient had at the same time a prostatectomy than the other patient, almost the same result. And well, the PSA was rising, and then he developed bone metastasis and lymph node metastasis. Then therefore was radiation. He had radiation, and then he started bicalutamide in May 2022. Then the progression of metastasis you can see, and he starts. I think it was pamorelin. So he gained 10 kilo weight. He had moderate hot flashes of still and no libido. That was for him the most important problem, no libido. But now the problem is that the PSA is almost 28, and he has last month an epilepsy, but no brain metastasis. He was vascular changes on the MRI brain. So now he has a choice between abiraterone, prednisolone, and enzalutamide. I called him this afternoon. But I have to say that I know him since 2018, and we spent many times since 2018 with all a lot of communication with this patient and his wife, and so maybe you will not be surprised that he chose for abiraterone. Why did he choose for abiraterone? Because he wants to remain driving his car, and the cars, he wants to go abroad to buy cars, and he was scared when he saw that by enzalutamide you could have hallucination. So he is afraid that if he has hallucination, he will not be able to drive anymore. And he said, I will do it until my death. It's so you see that shared decision making is a different process for everyone. Every patient is different, and you have to accept that some patient in shared decision making, that some patient makes a decision not to be treated. It's not the medical option we prefer, but if it's the option that patient wants, and it's difficult to fight against the decision. So to conclude, nurses are very important in guiding patients through the complexities of treatment decision, of course, and Their roles encompass education, emotional support, coordination of care to ensure that patients make informed choice that align with their values and preference. So again, I'm very sorry for the interruption. I hope it was not too disturbing for you. I'm waiting for your question.
Thank you very much. Thank you very much. No problem. We managed to solve it, and we managed to have you with us. I have one question for you. What tools or resources have you found most effective in decision share patient with metastatic prostate cancer? Do you use some kind of videos or leaflets? Do you use anything to give the patient a better comprehension of their disease?
Yes, we use leaflets. We have some leaflets in our hospital. Give the patient information on paper, and then we give them the information. We have an appointment for another discussion about what to read if they have any questions, just to help them. And I have to say, I cannot wait that the patient information is busy with shared decision making. Patient with hormonal therapy with this treatment, that they can make a choice. So I hope these treatment tools will come very soon on the EAU website.
And one last question for Corinne, and it's also placed in the chat box. The title of the webinar is empowering nurses to work in decision making in prostate cancer. So what would be the keystone here, or the mainstay, to empower the nurses to have or to be in a multidisciplinary and work in a treatment decision environment, let's say. What will be the key role of the nurses in this team?
What the key role is the role that it have many differences depending on the country where you are working. I'm very lucky because I'm working in the Netherlands, and the nurse practitioner has an important shared decision making, and we are involved. We are preparing the MDT. It's another role. But I know that nurses in Spain or other country in the south of Europe, they don't have the same role. But it's because I think that the doctor need to understand that we are able to do it. Someone talk about the price, how much it costs, but the nurse is not so expensive. Of course, the doctor is important, but we are a team. When the urologist will understand we are a part of the team, and not only sort of secretary. I'm sorry to say that, but sometimes it happens. In Germany, for example. When you will understand that the nurses have the knowledge, and can patients, and we are patients together in a team. The goal is to help patients. So the ego of everyone. We don't have to think on our ego, but to think of the patient. But to think the most important. It's the most important. That's why we are doing this work. It's for patient, not for ourselves.
Thank you, Corinne, for your comment. We have here from Eric. We need time. We have here from Corinne that we need to put our egos aside and place the middle of the treatment. I don't know if you have any further comments. We're almost reaching the last minute of the webinar. I would like to hear at least 20 seconds of each of you. What would be your last thoughts or your last for the audience on share decision in metastatic prostate cancer? We can start from your patient point of view. What are your last comments?
I think we will have to go to an optimization of the collaboration between nurses because in shared decision making they are sharing. So we are three, not just two. Thanks.
Corinne.
Yes, well, I agree with Eric. I think the same line. We are on the same line. I have to say that we need to, of course, to listen to patient and to accept no treatment could be a decision that we need to respect. It's difficult, but we have to.
Optimization, respect the patient, and the last thought from Dr. Vidal.
Yes. So I think you've said it. The most important thing is take time to talk to the patient. Tell them what they need to expect, what they may feel, and listen what they need to tell you as well. Inform them that listen to them.
So we need to work in a better strategy for treatment decision making, optimization of time, patient in the center. We not only need to talk, we also need to do what they have to say, because they have a lot of things and we can learn from their experience. So thank you very much. Our experts today. I want to remind the listeners that we will have this webinar placed in our YouTube channel in the next 24 hours. Thank you very much for being with us, and have a pleasant night.